Okay, welcome everyone. Good morning. For rounds this morning, we're having Daniel Cordovani give us an update on the undergraduate anesthesia program. Welcome, Daniel.
Thank you very much. What a crowd. I will give a moment for people to upload their codes so they're not thinking on the cell phone. And this slide for the code will be repeated 2 more times during this presentation, and it's also on the corner over there on the blackboard. Since I joined this department, I have participated in about, well, I don't know actually how many retreats. And one thing that I noticed is a very common theme in these retreats is this notion that we are not respected, that people don't understand what we do. And there is always this sentiment among anesthesiologists, either lack of respect or lack of understanding from administration, from hospitals, by other physicians, or even by the population at large. Just recently, I had a little celebration at my house on the side note because I became a Canadian citizen, and my neighbor came by, and it was quite interesting because the conversation, he was not ill-intended on his comment, but he did mention when he was talking to me, he was trying to understand what type of doctor I was, and when I mentioned to him, he said, "Oh, you just put people to sleep, right?" Which you cannot react the way you think you should, you cannot react the way you feel like you should react to this comment. But it's this notion that we just put people to sleep, when in fact this is the easiest part. I frequently say that if you have opposable thumbs, you can put anybody to sleep. It doesn't take much skills. It's more like I keep you alive for the surgery. But the complaining about the lack of respect, the complaining about the lack of understanding of what to do, it doesn't really do much. So I decided to take some actions to try to address that. And that's the main thing that I'm going to talk about today, under the umbrella of the update of the undergraduate program. So, because it's being recorded, my name is Daniel Cordovani. I'm the undergraduate program director here at McMaster University. And let's get started. I have no conflicts of interest. I do have a conflict on what I expected the outcome to be of this talk versus how I actually feel about it. So this is how I would like to feel, like at the end of this, you're going to just grab me by the shoulder and carry me out of here celebrating this great accomplishment and talking to everyone about what a great talk this was. But in reality, this is more like how I feel it might happen, me being this blonde little girl over here. And at the end of this talk, you might be commenting and talking behind my back, because I will say some things that people might not like. On a lighter note, most of the news are good news, but I will emphasize on things that we could improve. So here are the objectives for this talk. I will talk about what the new curricular delivery format is for the core clerkship. I will try to promote departmental engagement to improve the undergraduate program and discuss some opportunities to elevate the status of our specialty. But the update, I will kind of leave it to the end, because this is more basically telling you guys what we have done in the recent past. And well, just a quick update. So to recap, departmental retreats, that's what I felt anesthesiologists were doing. If you don't get the reference, don't worry, it just means you're old. And that's how I felt we should do. We should stop whining and do something about this whole lack of respect, why people don't understand what we do. So how can we elevate the status of a specialty? I feel that we could essentially try 3 strategies that come to my mind. One, involve anesthesiologists' involvement in leadership positions. This is not this talk. This is not what I'm going to talk about. But on a brief note, I feel that if we were to have more anesthesiologists representing us at hospital committees, university level, OMA, CMA, CMPA, this is how we get our voice heard. This is how we had to get represented. This is how we get understood. But other ways we can do that is educating the future doctors about our importance and educating the general public. So let me start with educating the general public. This is something that we capitalized on our undergraduate program to educate the general public. So the Canadian Anesthesiology Society has a student essay contest. I don't know if you guys are aware of that, but every year there is a contest. Each university can enter up to 3 essays by their own students, and then the winner, the first 3 get a prize at the CAS meeting, but only the first essay gets published. So only the winning essay gets published in Anesthesia News. So the viewership is very limited. Half a dozen people will read that, and all other participants that wrote very good essays, their essays never see the light of day. They put a lot of time and effort in it, but nothing gets done. But there is the Hamilton Spectator. We contacted the Hamilton Spectator to try to see how they felt about publishing those essays. They have 350,000 readers, and they just had a few sort of demands, not demands, like the framework. The essay had to be 800 words, which is much shorter than the essay that's normally written for the CAS essay. And it had to be appealing to a broad audience. So we had to extract any very more technical terms. And this is what we got so far. This was the first article that got published in which a anesthesiologist as an under-recognized medical specialty. Mike Howe, he's now anesthesia resident at University of Ottawa. He wrote this article, which started having a good repercussion. It even had a reader of the Spectator who, there is that letter part where readers can read, readers can write to the hospital, to the newspaper, and she mentioned how she had a very positive experience with her anesthesiologist. Basically, the anesthesiologist saved her from a postpartum hemorrhage, and she describes the role of the anesthesiologist in her care. Then there was another one. This student, she's currently applying for CARMS, but she's not applying for anesthesia. But she wrote her impressions about anesthesiologists after some, she had anesthesiologists as her MF1 tutors, and she spent one day in the OR. After that, she wrote her impressions of the specialty. This student, Edward, so the previous one was Rebecca Baum, now Edward Zoe. Edward Zoe, he wrote this essay that also had a nice repercussion. He basically says how the anesthesiologists are portrayed in the media. And he talks about the Grey's Anatomy, how typically the anesthesiologist is the villain or the coward. And this also had some repercussion in which another reader wrote to the newspaper commenting on how her dad was an anesthesiologist and the importance of her specialty. So the conversation started happening. Rui Hu, she's applying for anesthesia this year. She wrote this historical piece about Dr. Virginia Apgar and the importance. Basically, she talks about what the Apgar score is and pretty much makes it, now everybody should be, and the reader becomes aware that Dr. Virginia Apgar was not a pediatrician, she was an anesthesiologist. This is Mario, I can't pronounce his, Mario Kovacevic. Mario, he wrote this analogy about how if you're driving from point A to point B, and typically we see the surgeon as being the driver, but the anesthesiologist would be like this onboard mechanic that is fixing everything on the goal while the car is on movement. So while the car is on movement, you open up the hood and fixing everything to make sure that you get to your destination safety. He also wrote another piece talking about what it takes to become an anesthesiologist. This one, because it had to appeal to a broader audience, it ended up becoming an essay about essentially what it takes to become a doctor. So the competitive road to medical school. So this started having a snowball effect. Colleagues started sharing the article. After the first one got published, I got an email from a friend of mine who works, an anesthesiologist friend of mine at Joseph Bryant, who wrote me saying, "Oh, look what a surgeon showed me today." And I was like, "Oh, that's great. I knew about it." But that was quite interesting. A friend of mine who is my neighbor, he was commenting to me how his patients were talking to him about the pieces they wrote on The Spectator. The students get involved in a scholarly activity. They are promoting our institution. They are promoting our specialty. It's through their lenses, and it also enriches their CV, so increases their chances of getting to a good program. We're getting now 350,000 readers instead of half a dozen, and the articles are shared in social media, so they started circulating worldwide. And now it's a national initiative. When we presented this at the CAS meeting this year, after that, the outcome was that they included this little news. If you go to the bottom of the left here, news. And then in this part, it has a link to news in the public media related to anesthesiologists. So if you, there are more now you can show, but those were the ones that began. The ones that, those are the articles that the McMaster students published and then got put it over here. And other program directors across the country are now hopefully are going to encourage and try to capitalize on the student essay and also try to publish their articles on their local papers. Let's see what the outcome is going to be. But as they publish, this should start increasing. So as I mentioned before, one way to try to elevate our status and get us more respected, one would be leadership positions, educating general public. Now talk about educating the physicians. Anesthesia has been consistently the first choice for career for about 5% of the medical students. This is both both Canada-wide and McMaster. And we frequently feel, I hear that this is more hallway conversation, how, oh, it's nice to talk, it's nice to teach the student who is interested in anesthesia, oh, he's interested in ortho, why he doesn't care. And I would like to try to bring down this perception, because those 5% who are going to do anesthesia, those are the people who already understand our importance. They want to be us. Like, of course, I wanted their experience to be positive, but I would like us to emphasize the importance of educating the other 95%. And this has actually been captured in a few articles. This one was a qualitative study in which they interviewed some clerks. And I just will have some quotes from each of the studies that I will present, but this one, for clerkship students, career interest inquiries and how students respond can be high-stakes issues, potentially compromising teaching quality, equitable treatment, and fair evaluations. So essentially, what are you thinking of doing? They are frequently dismissive about the answer that they will give it to us because they fear that if they tell us that they're going to do a specialty that is not ours, the teaching is not going to be as good. We should try to address that. And this is one of the importances as well. This study, they compared the perception among his residents, staff, and students. But one of the things that was interesting, one of the reasons that they were trying to address is that there has been a declining interest in surgery, that was general surgery, among medical students. And one reason might be the third-year clerkship experience. So the experience the medical students will have with us, that will shape how they feel about us. For many of them, for the 95% of them who will not do anesthesia, that might be their only anesthesia exposure. So what they learned from us, how they feel about us, that's going to shape their perception. And if they have a good experience, this might also be an early recruitment strategy, because early exposure to the specialty is one of the things that trigger people's curiosity and will pursue that career. So though 95%, if they have a positive experience, they'll two potential outcomes. Either they're going to decide to do anesthesia, or they will at least understand us better and respect us more. And one thing that was interesting to know, and then I'm going to try to get some segues on the other topics, is that the medical students thought that feedback was poor compared with the opinions of faculty and residents. Mainly, message is, we teachers think we're better than what the students feel about us. So we think our feedback is good, they don't feel so much. Same concept, but here the students emphasize that they have a positive experience if they feel their supervisor is invested in their learning. So people who are making the effort to improve their teaching skills, that's valued by the medical students. This is a thing that I just want to emphasize. I want to put the contrast about how we feel we are doing and how the students feel we are doing. So this one among surgeons, 90% of surgeons felt that they were often or always successful in providing good feedback. Only 16% of the residents agreed with that statement. So we may not be as good as we believe we are. And this is the same theme. 61% of attendants who filled out the self-evaluation forms in this study scored themselves higher than what the residents and students scored them. So the learners score their teachers lower than what we score ourselves. So one of the messages that I want to convey to you is get your teacher effectiveness score. The teacher effectiveness score will provide you summarized, you're going to provide you all the comments that the students made about you. Every single comment the student made about you is going to be there. And it also provides you a more quantitative analysis. Basically, you know how your score compares with the other teachers. So take a look at that. This is to facilitate reflection. This is one of the things that is hard. We are usually poor in self-evaluation. That's across the border among physicians or learners. This should help our self-evaluation, or at least our reflection. So in October, what I do is I sent an email basically warning people. That's what TDS is. You're going to receive an email. And then you receive an email from MedSys. Currently, the system is MedSys sends an automatic email, and then you have to click on that link and put your password. But they have instructions if you don't have a password. It's really not that hard. I warn people, and then you receive that email, and now I'm doing it again in person, a presentation. So please just take a look, and if you feel like talking to me about your TES, just please send me an email. If you're having difficulty accessing your TES, please send me an email. It's very pointless for us to compile all this information if the teachers are not assessing that and then reflecting on that. And the good news, you can also claim CME points for that. For each 1 hour that you use assessing your and reflecting, you can claim 3 points, 3 hours. So it's section 3 for your main port. And a message that I also want to convey is that there is this conundrum. We teach better when the students show interest, but the student shows more interest when we teach better. And the reason I want to, what I want to say about that is that if you ever encounter the situation that a student is not interested, this is also how a conversation, oh, this student is not interested, this student is not that. It might be true. We do have some students who are not interested. We do have some students who are more challenging, but it is a minority. We have a great number of students who are doing great things here at McMaster University. I just mentioned a few that published things at The Spectator, and pretty soon I'm going to mention a few more. So if you have a student that is not engaged, just be aware that potentially it's not because they're not interested. It might be they're just afraid. They are terrified of us. I will provide now a few things. One is, I can't pronounce this word, so I'm not going to say it. Not because it's a word, I just can't pronounce it in English as a second language. The students, they are really afraid of us. Not only us personally, we tend to think we are the good guys, and we think that potentially surgeons are more terrifying. It might not be the case. We might be just at the same level. I also learned that from nurses, that some of them are terrified of anesthesiologists. So they might, not only us personally, but the whole environment. The OR is a very conflict-rich environment. They see people arguing, they see high-stakes stuff, they see patients having complications or near miss or near complications, and this is very terrifying. So if they are not engaged, be aware that it might be not because they're not interested, they might just be afraid, and that's their reaction to the situation in which they are not comfortable. At the end of the rotation, the students have the end of rotation evaluation. That's when they evaluate our rotation. So I extracted a few quotes that I will either read partially or entirely, just to illustrate the point. So the common theme here now is variability in quality of teaching. Variable by preceptor. Had one preceptor who had pretty short patience for teaching. So that if they have this experience one day, the following day, they might not be so engaged. There was considerable variability between preceptors in the procedure they would ask or allow me to perform. as well as the amount of teaching they would provide. So variability in teaching. Very variable depending on staff. Some were wonderful, while others did not want to be bothered by having students. So if they have a bad experience on that one day and they work with different people every day, that might affect how they will behave the following one. So just be cautious before you assume that the student's not interested. Expectations. Not every preceptor acknowledges the need for objective and does not always feel that the same fundamental ones are necessary. Varying levels of expectations. Took the first call shift, so this is the student that on the very first day in the OR, they did their call on that day. It was so stressful because the staff kept criticizing the fact that I didn't know how to do X, Y, and Z, even though I introduced myself and the fact that it was my first day. And they have these on the first day. The following day, they might be more reluctant about taking an action because they might fear that if they take an action, they will be reprimanded. Expectations of the capacity and skills of clerks varied wildly between physicians. On one end of the spectrum, I was told I should not write anything at all in the anesthetic record and was expected to mostly observe. On the other end, I was left alone with a patient and asked to give pressors as needed and expected to intubate without difficulty at the end of the rotation. So one that can't even touch anything, just have to sit and watch. The other one who is supposed to be by themselves managing cardiovascular events and intubating the patient. As an FYI, there is a study that I don't have it over here that followed first-year residents in the UK. In the first 10 attempts of intubation, the first-year residents were only successful 50% of the times. So that should be our expectation. They will fail for intubation, about the flip of a coin. What we should expect is being careful, gentle, know their limits. But we should not expect them to be successful. 50% of the times they will fail. Again, different staff variability. I found that everyone had differing expectations, were not clearly communicating. I felt unprepared for some staff and felt badly when I could not complete a task with confidence. I also did not feel supported by some staff. And then he also said that other staff were really good, took the patient, and he really appreciates it. Variability. They have a bad experience, they might remain. So if you see a student that looks like that they don't care, remember, maybe they don't care, but I would probably guess they probably are afraid. They're afraid of being reprimanded for an action. Which will bring me to the next slide, which is at the end of the rotation. As I mentioned, they do those at the end of the rotation evaluations. I extracted some quotes from last year. As of this year, at the end of last year, so we still don't have data because it was only started a few months last year, but the undergraduate program started collating data as well about mistreatment. That's an accreditation issue. There are different ways that students can deal with mistreatment. One is that to report student affairs, but there is one that the undergraduate program is trying to do, which is quantify, which I'm really hopeful our number is going to be low. And this is part of the reason I would like to encourage you people. Well, the message is very clear. So there are 4 questions in the end of the rotation evaluation that students are being asked. Do you feel that you have been mistreated by anyone? Did you witness anyone being mistreated? And then, have you discussed your concern? Would you like to elaborate on your experience? So I will only have partial data in January, February about this first semester, and then by August, September, I should have for the whole year. And this is probably going to be discussed at the clerkship committee level for us to compare how different rotations are doing. I'm really hopeful that our number is going to be low, hopefully the lowest. So the message is an Ellen DeGeneres message, is be kind to one another. If you don't get the quote, again, you're just old. But it's a little bit more than that. Is to remind people, if we go back to what the Royal College is trying to tell us to do at the postgraduate level with CBD, we are coaching our residents. The idea is to coach our residents. What does that mean? I'm not going to elaborate on that because that's an endless discussion, but I will point out to one key component of coaching, which is ask more and say less. And this is a book in which this guy is from the corporate world, and that's the main message. Say less, ask more, and change the way you live forever. Not not really endorsing this book. I actually read it. It's not, there are some cool things, but it's not that great. There are a few things that are interesting. But the message is, if you see a student that appears to have a certain behavior, just double check what it is. Don't make the assumption that the student is bad, unengaged, or just ask the question. Ask the question. You might even say, you seem not engaged, you seem not interested. You might say that your perception, but then ask the question, why, confirm if that's true. You will be surprised. They also have lives, personal lives, and many times it will be, oh, yesterday I was told not to touch this. Oh, yesterday my staff told me not to do that. And then today you're expecting him to do that, and he's not. Just ask the question. There is huge variability in our expectations. And now I'm going to try to mention one way we try to can unify a little bit our expectations. So the comments are not all bad, and I will emphasize that when we collate the quantitative analysis of the end of rotation, 85% of the students at McMaster actually have a positive experience, either good or excellent. So 85% of the students do feel that their undergraduate program is good. But I'm focusing on the bad because I want to focus on how to improve. These are also some of the quotes from the end of a rotation. Clear learning objectives document with sub-objectives included essential clinical experiences. Amazing decision. EC probing questions were great. Thank you for the EC probing questions. So this was also a project that is student-driven. Janice Yu, she's not here, she's our first-year resident. She was involved in that when she was a student, along with other two residents, in which we created some questions to try to guide what the students should learn and should guide what to discuss in the operating room with your students. So if you don't know what the expectation should be, we have the ECE tracker. So I will comment a little bit about how the undergraduate program works. So we have the ECE, MacDot, MATSIS, and yes. So if you go to the ECE tracker app, my version is different than this version from the students because the students are able to log their activities and I'm not. So just to illustrate, anesthesia and the obese patient, they have to at least see or discuss that once. But what should they learn about this discussion? They should be able to answer those three questions. Discuss how management may be impacted by obesity, how about ventilatory strategies, how can obesity impact the pharmacokinetics of certain anesthetic agents, list 3 comorbidities. I don't know, anesthesia in the patient with cardiovascular disease. They will see a patient that has hypertension, coronary artery disease, whatever, or you just discuss that. They don't necessarily need to see it, but they discuss. But what should they learn from the discussion? How could you adapt your technique in terms of monitoring? So it's about talking about doing an arterial line, 5-lead EKG. What about adaptation of technique in terms of selection of drugs? Talk about how propofol is a negative inotropic agent and you can change some of the agents. So those are the expectations. The expectations are there for the students to know and for you as well if you want. You can just download the app, it's free, and then you start using it. But even if you don't have the app, you can use the students app. So just know that if you're not certain what to discuss with the students, the ECE tracker should provide you very clear guidelines on what the students should see, discuss, and what they should learn about it. This is something for the students to do and based on trust. We don't have to track that. The students are supposed to know what they're missing and what they should do. It's up to them, so you don't have to worry about it. I just want to emphasize that you have access at your fingertips. You can see, and it might help you, guide you what you're going to discuss with the students. The other one is the MacDot. MacDot stands for Direct Observational Tool. The Direct Observational Tool is a tool for, a background. Accreditation for the undergraduate program happened, and one of the weaknesses in the accreditation was lack of direct observation of students interacting with students. Oh, that's not a problem for anesthesia. We work one-on-one. Yeah, very good statement. I agree with you for the most part, but there was documented that 25% of the students were not observed doing the pre-op assessment. So overall, yes, and the pre-op assessment is only one of the components of our rotation, but if in our rotation in which we're working one-on-one, 25% of the students mentioned that they're not being directly observed, this was a bigger problem in other rotations. So the cure for that was to create a tool in which they could document for students, so it's to address the accreditation thing, and now they can prove to the accreditors that they're being observed, and it's a formative tool for the students. So again, we don't have to track the students are supposed to do those. What you tell the students on this, it's only for the student, it doesn't go in their final evaluation, but they have to be observed doing a few things. And this, you don't have to have the app, but this is for the student. But if you go to the McDot, and they're going to log an observation for anesthesia, these are the things that they have to do. Obtain pre-anesthetic history, they have to do a pre-anesthetic area exam, they have to be observed doing bag mask ventilation, they have to be observed doing direct laryngoscopy, and they have to be observed communicating with the patient what the anesthetic plan is. That's what they have to do. It doesn't say that they have to be successful. They might fail, it's fine. And then you put a little comment. Don't kill patient next time. Make sure all the teeth are still there. You put a comment. The students, the MacDot is already pre-populated with some comments. Unfortunately, those comments are standard for all rotations. I've tried multiple times to try to make it geared towards our specialty, but it would be too cumbersome for the Med Portal team to do individual comments for each rotation. So right now they're standardized. So some of the comments are completely irrelevant. So explain to the patient as you're going through it. You're not going to explain to the patient as you're intubating what you're doing. Most of the comments are completely irrelevant. So one thing that I manage at least to influence is that there is a text box which used to be at the very bottom. Now it's at the very top. So for the most part, I'll say ignore the comments, the pre-populated comments. Just text it in something, a feedback. It's very to the point. Don't have to elaborate too much. Is bring the face to the mask. Don't smash the mask against the face. Improve yourself. One comment. And coming back for the presentation, you have the MedSys daily evaluation. So ECE, essential clinical encounters the students have to do. Each rotation has different ones. That's a part of the overall curriculum. MacDot is only for them to be observed doing a very specific task in which, in our case, everything can be done in one day. If they talk to a patient, do an area exam, and then they bag mask and intubate the patient, all of them are done in one day. But they still have the end of the day evaluation, which means that it doesn't matter if you filled out a MacDot on that day. It doesn't matter. The end of the day evaluation, it still needs to fill out. And this is the ones that you probably have seen. They pull out on their phones, their cell phones, their laptops. You don't have to worry about that. It's the student who initiates the process, just gives it to you, and you fill out the evaluation. You as a resident, you would fill out just like a faculty. If you supervise a medical student by any chance, you would fill out just like if you were a faculty. This is the only thing that actually goes into their final evaluation. And I would encourage you to please write a short comment at the end. Those help a lot. Most people do put a comment, but those, I don't say most, but frequently there are comments, enough comments, but those are important. Those is what paint a picture. And remember that not everybody is exceptional. Most people meet expectation. And then if they do something exceptional, please make sure to grade appropriately and comment on that. And if they're below, also make sure to grade appropriately and make a comment on that. Comments like, oh, today we discussed this, this, and that, that's not exactly what we're looking for. The topics that you discuss, it doesn't really talk about the patient, the student's performance. Yes?
Is there like a pass or fail thing? Like if a student receives few comments, how do you grade? Do you fail somebody? Send to remedy something?
Okay, I'll try to do quick on that so I don't so yes, if a student consistently gets below expectation grades, this potentially means he will not satisfactorily finish the rotation. So that's why it's important, because if you feel that the student's underperforming, but you decided to give it a shot, oh, maybe it was just a bad day, maybe it was just a bad day, and if everybody feels this way, we don't have the consistently negative evaluation of the student. And it is important for the student to know early into the rotation that they are potentially not going to complete it successfully. They can't learn at the very end saying, hey, this rotation just finished, yeah, you didn't do so well, you're not going to pass. they should be alerted about this potential early on. So if you say on the first day that they're not doing so well, second day another person, I receive an alert. Whenever a student receives a negative evaluation, I receive an alert and I pass it on to the final evaluator. It's not because it's alert, alert. No, some people should have a negative evaluation. It's more for us to keep our eyes on the student. We have a short rotation. A principle of the undergraduate program is that a student needs to be aware that they might not complete the rotation satisfactorily early on. Long rotations have a mid-rotation evaluation. We don't. We have daily evaluations. So that's why I get flagged for every single negative evaluation. And then I inform the people who are involved. So it could happen. It's rare. It's rare. So far, I think there were only 2 students so far that I had to not allow to complete the rotation. They had to repeat later. How the rotation works. And how the rotation works. There's Module 1, Module 2, Module 3, Module 4, Pro Comp, and exam. Module 1. Module 1 is the first day of the rotation, is lecture-based. Module 2 is the second day of the rotation, so they're out of the OR, and there's a case discussions, and then they do some IV and airway practice in mannequins. Module 3 is the clinical component of the rotation. That's the actual OR experience. So it starts on a Wednesday, because Monday, Tuesday, they are out of the OR having teaching. Wednesday, they are in the OR. Module 4 is the simulation, the last day of the rotation. They shall have a professional competency session and the exam. Their final evaluation is going to be based on their attendance and participation in the academic sessions, Module 1, 2, 3, Module 1, 2, 4, and Pro Comp, on their daily clinical evaluations on Module 3, and on the grading of their exam. So it's more than, so the importance of a single negative evaluation is very little. It's going to dilute if everything else is great. So don't be afraid of giving a negative evaluation if the student deserves one. And now I'm just going to mention about a lot of other accomplishments of great students. So sometimes we talk about the students who are not doing so well. I mentioned the students who accomplished great things, and I mentioned the Spectator articles. Now, I'm going to explain what the Module 1 now is. Module 1, the first day of the rotation, used to be in-person, face-to-face, with a faculty. But that was a few problems with that. We were utilizing a person with high clinical skills to regurgitate information from a slide. That was challenging because every 2 weeks we would have to have an anesthesiologist out of the OR for the whole day to do that. And it was challenging to do that. And on top of that, there are some other administrative difficulties. For instance, St. Joe's now have that dovetail training, and they are not really flexible on the timing of the day that they will offer those trainings, and we were having to adjust all of our teaching accordingly. Now, Module 1 is the students have the day off to do this online course. It takes them about 7 hours to do everything. So that's why also they have the day off. It would be very equivalent to having them sitting all day in a lecture hall having lectures. But now they do it at home at their own pace. They can start beforehand, and it doesn't interfere with other things such as dovetail training. For the creation of this online course, the way it was done is each student did a topic. It's missing one. This is incorrect. It's missing one. There is one more. But basically, each student picked a topic, and this student, she did the orientation, and she also did the OB patient, and this student did it's not missing. It doesn't matter. This is details. I will update when it's actually uploaded. I'm sorry. But essentially, there is one more course, and each student picked a course. They created the online course, and then they were paired with a faculty or a resident, and those residents provided content support. Also, a student-driven initiative, and this created this online course. Those students, I'm going to see some here, and Carms is coming. Those students are currently applying. Kat Butler, Natalie, Gabriel, Russell, Jean, and Sasha. Those students are all interested in anesthesia and applying to anesthesia. And they did a fantastic job in the creation. I will demonstrate in a moment. But I also want to take a moment to acknowledge Dr. Ilana Baer from the Learning Technology Lab and Dr. Anthony Levinson from the MedPortal team and the MedPortal team and the Learning Technology Lab, because they provided all the support. So Ilana Bear, she trained all the students on the software, on how to create online modules, on the didactic components of an online module. Then staff, anesthesiologists, and residents provided content support, and then Dr. Anthony Levinson did all the uploading to MedPortal and is doing all the maintenance. And let me show you how it is. So if we come over here into MedPortal page, on the upper right corner, undergrad, clerkship, anesthesia. And the anesthesia page will have pretty much all information that you would need to know, explains the rotation. It's pretty much this talk that I'm doing right now. All the contacts of every person, and I will mention all those people later. The student representatives, and they have here Module 1 e-learning course. They start the course, and then they have those 10 modules. They click and they start. And then they would, welcome to the anesthesia rotation. My name is Daniel Cordovani. I am the anesthesia undergraduate program director. I hope you will enjoy your rotation. And let me get out because my voice is really, really stupid. But just to illustrate what it is, and then I want to show some of them. For instance, the anesthetic machine, which was a constantly feedback we received in the other rotation evaluation, in which they would say, oh, we don't understand. So remember, you have to explain, but now before they come to the OR, they can actually do this, and this is interactive. Please click on the ventilator controls of the anesthetic machine, so they know what's the difference between the ventilator controls, where the vital signs, where's to flush oxygen. So it's an interactive, created by the medical students with the support of a faculty, and it's been a fantastic job. So of course, I'm not going to go over all the modules, but they are really well designed, interactive, with some glitches that were already identified, and they're going to be constantly being uploaded. But so far, the feedback has been very good from the medical students. They're really happy for a couple of reasons. One, they don't have to come to the hospital for teaching when they can do at home, which is a challenge for medical students because they never know the schedule ahead of time, and it's hard for them to accommodate. Now, 2 to 3 weeks before they receive, welcome to the anesthesia rotation, your first day is off, they can already book whatever they need on that day, and they know that they have to complete that, and we track that. So it's not like, oh, you have the day off. In order for them to write their exam, they have to bring a little certificate, which is the certificate of conclusion of the online module. So they finish, they print it off, and bring it to us for the end of the rotation. And this also aligns with what's called the flipped classroom model. The flipped classroom model is instead of you have a lecture and then you go do the homework, is you do the homework, which is the lecture, and then when you come to interact with your teacher, you are doing for higher cognitive skills. So module 2 is with the second day of the rotation. They will try to apply some of that knowledge. So they'll have case tutorials. They discuss a case. Currently, they discuss a case with a COPD patient coming for surgery. They have a pre-op assessment case in which is a little interactive, which is the lecturer, which is for the most part going to be a resident, but sometimes a faculty will pretend to be the patient and they will ask some questions. And then they also practice IV and airway in mannequins. So we're flipping. First day, lectures, you see at home. Second day, you come discuss it. Module 3, third day, it's Wednesday. First day of the rotation, they will start. So new cohort of students every other Wednesday. The importance of that is, if it's Wednesday and you have a clerk, 50% chances you have to explain the most basic things to that student. Be aware of that. Every other Wednesday, you have a student who will know nothing. You have to explain them how to draw up propofol. I would encourage you to allow them to do it without your support first for your own entertainment. It's really enjoyable to see all this propofol squirting all over the place. And then later, after you make fun of them, gently, you explain to them how to do it. You have to explain every single component. You have to explain how the anesthetic machine works, the flow of the patient. At this first day, they're not expected to know about their patient. They're not expected to know how to draw up drugs. They are being told that later on, second day, they're expected to see their patients ahead of time, know about their patients, see their patients, either with you present or by themselves, if it just has been the agreement. And they're being asked to take the initiative to prepare equipment, test the laryngoscope, test suction, draw up typically propofol and rock for most cases. And they're also being told to verify if emergency drugs are available. Not necessarily draw up. Some people want to draw up from the bag, some do not, but at least they have to verify if ephedrine, phenylephrine is there, draw up the propofol and rock, test the laryngoscope, test the suction. First day, they're not expected to do that, and you are expected to teach them how to do it. Last day of the rotation is the module 4, in which they do the simulation of OR cases under general anesthetic, all of them. They work typically in pairs, and I won't elaborate much on that. They also have the professional competency session, which is focused on team communication and patient safety. So this has been a session that has been revamped a couple of years, 3 years ago, because before it was too generic. It was everything about pro-comp. We focused on only team communication and patient safety. If you have never done this session and you're interested, please contact me. This is one of them. This is probably one of the ones that I enjoy the most. It's quite revealing their experiences, how they see when you go through that. This is not a PowerPoint presentation. This is just discussion. They bring their experiences of what they saw, in which communication either enhanced or nearly harmed the patient, and they bring for discussion. And it's interesting to see what they experience, how they see it. So how they stress and it becomes very evident to their fear, how they feel reluctant about bringing concerns, how they, for the most part, they shut up. And if they bring concerns, it's normally in the form of a question. That's a recurrent theme. So when you have your student saying, at what point would you give some vasopressors? What he's saying is, this patient is hypotensive. Did you notice? They don't really know at what point. They're just trying to tell you what point. And that's what, they're just trying to bring your attention to that. Sorry, yeah, I make those voices every once in a while. That's their way to try to deal with hierarchical concerns. They ask a question to bring your attention to something that is bothering them. Your reaction might be, if you address that question, this should solve. Either you didn't notice and then you address it, which is, I would say, probably typically it's not the case. For the most part is that we're not worried, but then you explain to them, oh, I'm not worried yet because they're about to do the incision, so blood pressure should come up. Perfect. They learned something, it was addressed, and they got their questions answered. It's quite revealing, but it's also quite revealing what they see in terms of conflict in the OR and how they deal with that. If you're interested in facilitating one of those sessions, talk to me. And then there is the exam, which is the multiple MCQ. People that make it happen. So I will try to bring their names here. Michelle, she's the program coordinator. She stays here in Hamilton. And then she has her counterparts in Waterloo, which is Lisa, and Christine in Niagara. Here in Hamilton, we have myself as a program director. We have Thomas Van Helder for the Hamilton General Hospital as the site director there. Saida Nair for the Juravinsky Hospital. Amanda Whippy for Mumsy. And Rafik Bolis for St. Joe's. This is important, I think, particularly for the residents. Frequently when there is an issue with students, you end up contacting your CTU director related to your postgrad program. Know the people. Those are the people related to the undergraduate program. And Saida came replacing Elena. Elena, thank you very much for not only for your transition when you were the program director and transition to me, and then for taking on the role of site lead at Juravinsky. Now Saida took on this role this year in September. Amanda Whippy replaced Mike Parrish. Thank you very much, Mike, not only for taking this, but also for all the support when I initially took the role. Amanda took on this role last year. And Tanya Ligori was the site lead at St. Joe's. She also stepped out this year, and Rafik replaced her. In the distributed sites, we have David Lagroteria in Niagara and Kevin Latchford in Waterloo. And in Waterloo, there is also a representative for the Cambridge Memorial, which is Mark Hindle, which is, he was a resident here just a few years ago. Mark Hindle just replaced this year Laura. Laura, she took a site chief role, and she stepped out of this role, and Mark Hindle is replacing her. We also have student representatives. We have Jenia, that's hard to pronounce, it's Jenia. He's a representative for Hamilton, and we have a representative for each campus. In Waterloo, we have Russell. He's applying to anesthesia this year, and he was the one who did the online module on regional anesthesia. And we have Qiangxi. She's from Niagara. All their contacts are in the MedPortal page, anesthesia clerkship page on MedPortal. If you're ever unsure about the undergraduate program, I frequently updated the anesthesia MedPortal page. You go there, most of the things you need to know should be there. And now I'll take a moment to talk about some ongoing projects. Dylan Horth, our resident, he's doing a clinical educator diploma right now. And quite selfishly, that's hard to say, I will take advantage of that. He approached me to supervise him. And I'm fortunate that he's trying to use our undergraduate, our clerkship program as his laboratory for some of the things that he needs to accomplish. So Dylan's going to help me out about revamping our MCQ. Our questions are outdated and they're not really well designed. We're updating that, creating new scenarios updating the scenarios for simulation. There is also the narrative medicine workshop. Saru Sharda, she's an anesthesiologist. She's part of our faculty. She's now working in Oakville. She's a writer and she's a writer coach. And she's been doing narrative medicine workshops for physicians for a little while. We created now this workshop series for medical students. We just did our first session now in late October. We have another one in December and another one in January. So it's a 3-part series. We have done it already. First session went amazingly well. We had a waiting list. Within 24 hours of us launching it, that we're doing that, we already had a waiting list. We were only accommodating 10 people. Within one day, we already had 15 students interested. And we're doing that. And one thing about that, besides the education of the medical student, this is not exactly anesthesia related, it's just anesthesia driven, because it's me and Saru, 2 anesthesiologists doing. But it's for any medical student. But one interesting thing about that is those are the students who are interested in writing. So my not so hidden agenda is at the end of the workshop, I will approach those students, see if they're interested in writing for the CAS essay, and try to see if they will provide good essays to enhance our chances of us winning the essay again this year and having more material to publish at the Spectator. So there is also something that will come out, hopefully, out of this narrative medicine workshop. And the other thing is distributed site electives. We receive way more requests than we can accommodate here in Hamilton. So we're trying to expand so to have the regional sites also take elective students. And our first one is on Oakville, because Saru is there. She's willing to take students. And then there are some other anesthesiologists that are willing to take students. The chief was very supportive. The administrative people were supportive. We had some barriers in other centers in which they're interested in residents, but not so much in students. I will gradually talk to those people, but we're expanding. And this hopefully we are going to be able to have more students doing electives in anesthesia. I think this is an important component. If we want to promote our profession, our specialty, we have to have more students doing electives. But we can't have them all doing here in Hamilton because we don't have enough space. And talking about electives, I'm going to briefly comment on block electives and horizontal electives, just for people to know what it is, because I sense that not everybody knows the difference. But block electives, 2-week electives for a clerk is somebody who is already in clinical clerkship. They stay with us for 2 weeks. Those are people who are typically already interested in anesthesia. Horizontal electives, for the most part, they're first-year medical students. They know nothing about anesthesia. They know nothing about nothing. What they're here for is to sample our specialty. So they come to the OR for 1 day, maybe 2 days. It's only for them to get a sense of the specialty and see if that triggered their curiosity. This is extremely important. Early exposure to the specialty is one of the main components that will influence your career decision. So it is important that we have them in their first year so they will get interested in our specialty. And this functions as an early recruitment strategy as well. If we have more people interested in our specialty, it's more likely that we're going to have good medical students. We're going to be able to select the best students to our specialty. And my message is please supervise a student. This is our ongoing theme. Like our current system that is voluntary basis, we're Mike Parrish, Amanda Whippy, Andrew Surratt, the residence representative, we had some conversations. We're going to probably in the future have more conversation with James Paul and the chiefs about how to improve our current system. But I would encourage you, please take a medical student as an elective. If each faculty would take one elective student per year, one block and one horizontal, problem solved. Each faculty would only have to take one student per year for us not to be having to send emails every time, can you take this, can you take that, can you take this? But currently we have a handful of people who are taking all the students. So the workload is not very well distributed. It's burning out some faculty who are getting tired of supervising students over and over again. When we have 80 anesthesiologists in Hamilton, each one takes one student, that's all we need per year. So this is just to emphasize the point. So my objectives were inform the department about new curriculum delivery format, promote engagement to improve the program, and discuss opportunities to elevate the status of our specialty. I hope I have accomplished that. This has been said already before. I can't remember where the quote comes from, but a vision is only a vision if it's shared. If it's not shared, it's not a vision, it's a hallucination. My vision is that we would be the best rotation among all the clerkship rotations here at McMaster. And my vision is that McMaster will be the best undergraduate program in Canada. I hope you guys will join me to try to make that happen. And I can discuss later what are the metrics for us to find out if we are successful. Thank you. Sorry, that was packed with content, so not so much time for discussion, but some.
Thanks, Daniel. I just have a technical question. Maybe you can help me now or later. I downloaded the ECE app, Eccentric Clinical Encounters, logged in with my med portal email and password, and it says I'm not registered as a faculty or a student. That was there. So what's the next step?
So support at medportal.ca.
Okay.
Support at medportal.ca, or write me, cordofd@mcmaster.ca, and I'll make it happen. But the support team, normally if you say that I'm a faculty, I would like to have access, and you just have to disclose this as a faculty so they don't give you access to log the activities.
Okay.
Any other comments? Oh, people walking out of me, my middle child complex just flaring up. Yes?
I just want to really acknowledge the fantastic work you've done, Daniel. Very innovative. You've really transformed the anesthesia clerkship. I actually was the original program director when we didn't even have a clerkship, and we initiated in 2001. It's really it's amazing what you've done with it. So I want to thank you so much on
Thank you.
our behalf for the innovative ideas that you've come out with, and really we have actually in a very short time elevated our exposure in the public with the Hamilton Structure. I thought that was just brilliant, and it's going right across the country as well. So really want to thank you for that. And I think the points that you talk about in terms of communication and mistreatment and that sort of thing not only applies to our medical students, obviously to our residents. It's something that the university is really focusing on and taking very close note on that. But certainly, as you say, in the pro-comp, it's not just the idea of civility, but actually it's a safety issue. Because as you say, oftentimes students, if they feel intimidated, they're not going to point out their mistakes, or they're going to put that tube in under pressure, thinking, knowing that they have no idea where they're putting that tube in. Could be in the trachea, whatever, but someone breathing down their throat or, having unrealistic expectations. It's more likely to happen that an error would happen, or they're not going to disclose an error. So I think those points that you make are really encouraging.
Well, thank you. And I'll actually use an example that a student brought to my attention in one of the professional competency sessions that illustrates the point of when they're intimidated, which is it's sort of lower stake, but illustrates the point. The student had identified that the antibiotics had not been given, but she felt reluctant about raising that. And later, it was, we didn't give antibiotics. It was given after incision. But she had identified that had not been given, but she didn't say it. It's because they're intimidated. So the whole creating a welcoming atmosphere, that goes a long way beyond their perception and enhancing our specialty status. It goes up towards patient safety as well. There was something else that I was going to mention today. Please, any other comments? Mm-hmm. Yeah?
I just want to also repeat the same words from men. Like, what you've done is pretty amazing. I just want to congratulate. It's very actually inspiring. After, it's a way to go, and it's been amazing.
Thank you. The other thing that I forgot to mention, which is an administrative thing about the online course that helps us a lot, is the challenge that we faced typically twice a year on the days in which it's not a public holiday, but it's a hospital holiday. So it will happen next Monday, in which is a hospital holiday, but it's not a university holiday, in which we could not find anybody to teach, but the students are supposed to have their teaching sessions. And happens again in Easter Monday, in which it's not a university holiday. So the students are supposed to have their teaching session, but everybody's in a holiday, so we can't find anybody. Now with the online course, it's no longer an issue. You have the day to do your online module. It's not a holiday. It doesn't matter that faculty are not available. You can do it on your own time. So we address many things: dovetail, holidays, difficulty recruiting people to do the teaching sessions, and it might also reflect, this is going to be minor, but it might also reflect in our point system, because now it's 16 less people claiming points for AFP. Thank you.